I want to introduce you to the 12th Annual UC Davis Pre-Health and Pre-Medical National Health Conference. Up next, we have Emergency Surgery presented to you by Dr. John Ma, the immediate past president of the Northern California chapter of the American College of Surgeons, as well as the chair of the University of California Office of the President Tobacco Control Program. Please give him a round of applause.
Thank you, Candace, for that wonderful introduction. Thanks to all of you for being here. I'd like to begin by thanking David Ivanoff and Jubin Ashfar for this amazing conference. Congratulations to all of you for the amazing opportunity to be part of this investment of your time to define your future career success. I'd like to congratulate Dean Freischlag as well. Welcome her to UC Davis. It's really a tribute to all the energy and all the leadership of the students. I am pleased to speak about the field that's emerging of emergency surgery. This is something that you may not have read that much about online. It's something that I've been trying to champion really as a blend and a reinvigoration of trauma surgery and general surgery. And it really speaks to two separate programs, the acute care surgeon and the surgical hospitalist, that I believe are unifying in this new exciting career opportunity. I'm going to speak to you about the reasons to choose a career in surgery in general, then to focus on why to choose a career in emergency surgery in particular, to share with you some of the transformative events that have occurred recently and what I regard as the exciting new steps moving forward. Some of my research most recently has focused on characterizing the impact of smoking on surgical outcomes, and that's the programs that I've been leading at the Office of the President. We'll start with this slide. This is a television show that was created probably before most of you were born. It's the television show ER. It was a fictional series that was based in Chicago, and it told of the successes and failures of a group of emergency nurses, surgeon, and emergency medicine providers. Do you recognize the person third from the left in the? It's George Clooney. ER was really the television show that led to his fame and an increased number of movie roles. It also had the very positive impact of really attracting a number of medical students to a career in emergency medicine. You're probably more familiar with this television show more recently, Grey's Anatomy. This is an interesting image of the cast of characters, I guess a few seasons ago, and there's a quote here that I find of great interest. Obstacles are put in your way for a reason, to see if what you really want is worth fighting for. I think that's very relevant to a career in medicine, to a career in surgery, and also to a career in emergency surgery. It's kind of interesting, you know, up top we see McDreamy during an operation. This is what it's like to be inside of the operating room. A question for you, does anyone know what the inspiration for the creation of the show Grey's Anatomy was?
The creation or the title? Never mind.
Okay, very good. The title, I would imagine, is the anatomy textbook. How many of you are familiar with the trend nationally to try to use checklists to improve aviation and medical care? Are you familiar with, have you had the chance to read the book, The Checklist Manifesto? I read an interview with the creator of the series, and they said it was actually this person's first book, Atul Gawande. He's a professor of surgery at the Brigham. It was his first book, Complications, that was the inspiration for the show Grey's Anatomy. Each of the characters on this show is based on a chapter in that book. I wanted to share with you, to understand what it's like to be a trauma surgeon, what that field is like, I wanted to read to you the introduction. So I was chatting with a medical school friend of mine who is now a general surgeon in San Francisco named John. We were trading war stories, as surgeons are apt to do. One of John's was about a guy who came in on Halloween night with a stab wound. He had been at a costume party and gotten in an altercation, and now here he was. The patient was stable, breathing normally, not in pain, just drunk and babbling to the trauma team. They cut off his clothes with shears and looked him over from head to toe, front and back. He was of moderate size, about 200 pounds, most of the excess around his middle. That was where they found the stab wound, about 2 inches, a slit in his belly, through which pouted, through an opening like a fish mouth, a thin mustard yellow strip of omental fat. Fat from inside the abdomen, not the pale yellow superficial fat that lies beneath the skin. They'd need to take him to the operating room, check to make sure the bowel wasn't injured, and sew up the little gap. No big deal, John said. If it was a bad injury, they'd need to crash into the operating room, stretcher flying, nurses racing to get the surgical equipment set up, the anesthesiologist skipping their detailed review of the medical records. But this wasn't a bad injury. They had time, they determined. The patient lay waiting on the stretcher in the stucco-walled trauma bay while the OR was readied. But then the nurse noticed that the patient had stopped babbling. His heart rate had skyrocketed. His eyes were rolling back in his head. He didn't respond when she shook him. She called for help, and the members of the trauma team swarmed back into the room. His blood pressure was barely detectable. They stuck a tube down his airway and pushed air into his lungs, poured fluid and emergency release blood into him. But still, they couldn't get his blood pressure up. So now, they were rushing to the operating room, crashing, stretcher flying, nurses racing to get the surgical equipment set up, the anesthesiologist skipping the review of the records, a resident splashing a whole bottle of betadine antiseptic onto his belly. Even before draping the patient, John grabbed a fat number 10 blade and sliced down through the skin of the man's abdomen in one clean, determined swipe from the ribcage to pubis. Cautery, he asked for. He used the electrified metal tip of the cautery pen along the fat underneath the skin, parting it in a line from top to bottom, then through the fibrous white sheath of fascia between the abdominal muscles. He pierced his way into the abdominal cavity itself, and suddenly an ocean of blood burst out of the patient. Drat. The blood was everywhere. The assailant's knife had gone more than a foot through the man's skin, through the fat, through the muscle, past the intestine, along the left of the spinal column, and right into the aorta, the largest and main artery from the heart, which was crazy, John said. Another surgeon joined to help and put their fist down on the aorta, above the puncture point. That stopped the worst of the bleeding, and they began to get control of the situation. John's colleague said he hadn't seen an injury like that since Vietnam. The description was pretty close, it turned out. The other guy at the costume party, John later learned, was dressed as a soldier with a bayonet. The patient was touch and go for a couple of days, but he pulled through. John still shakes his head ruefully when he talks about the case. There are 1,000 ways that things can go wrong when you've got a patient with a stab wound, but everyone involved got almost everything right. The head-to-toe examination, the careful tracking of the patient's blood pressure, the pulse and rate of breathing, the monitoring of his consciousness, the fluids run in by IV, the call to the blood bank to have blood ready, the placement of a urinary catheter to make sure his urine was running clear, everything, except no one remembered to ask the patient or the emergency medical technician what the weapon was. Your mind just doesn't think of a bayonet in San Francisco, John could only say. I wanted to share that story with you because those are the really exciting stories of a career in trauma surgery. It's an amazing path. Those incredible saves I've learned over the years very often are the ones that really inspire medical students to consider careers in trauma surgery. I'm actually a general surgeon, and I did a fellowship in healthcare policy, not in trauma surgery, but I wanted to share with you a lot of the exciting developments in both fields. This is an image of a surgeon in repose. There's a quote from John F. Kennedy that talks about the challenges of going to the moon and doing great things, not because they are easy, but because they are hard. And that will serve as a way to organize and to measure the best of one's energies and skills. It's a challenge that one is willing to accept, that you're unwilling to postpone, one that you intend to win, and the other things as well. And I think that really signifies, it is difficult to be a surgeon. It's an amazingly rewarding career. It's rewarding because it's difficult. If it was easy, then everyone would do it. It's rewarding because it's hard. In terms of the work of surgeons, it's amazing to have the opportunity to travel through all these different settings within a hospital. The ICU in the upper left, working with anesthesiologists in the upper right, in the operating room team in the lower left, or examining patients in the ER. One of the great strengths of a career in surgery, in trauma surgery, in general surgery, is to master human anatomy and physiology, to comprehensively understand the patient, but also to comprehensively understand how a hospital works. And I think that we're witnessing a number of surgeons are emerging as national leaders in health reform, for those of you who might be interested in a career in public policy and government. This is an image of at a retirement party with Atul and myself from a few years ago. It's quite interesting to see the evolution of the field of surgery. I wanted to share with you, to describe to you first what it is really that a surgeon does. And if this is something that is of interest to you, then you should definitely take a close look at general surgery. So to a surgeon, patients come with a chief complaint. They're having symptoms, something's wrong. The first step is to interview the patient, to ask them questions, to inquire about their past medical history, their past surgical history, their medications, and their allergies. After that, you perform a physical exam, and your skills as a diagnostician to look for clues on physical exam, you're trying to identify the diagnosis and whether this patient needs an operation. Next, you'll likely have an initial set of laboratory tests to review and an initial set of x-rays. And so at this point, you'll reach a juncture, and you will either say, yes, there is enough information here. I believe I know what the diagnosis is, and I believe that this patient will be benefited by an operation. Sometimes you'll reach this point and realize, yes, I know what the diagnosis is, and it doesn't require surgery, and you refer those to another specialist. So in the event that the answer is yes, then you, in the elective setting, schedule the patient for surgery, which may be a few weeks into the future, which gives you time to have anesthesia clearance. You begin to prepare the equipment and the steps of the operation that you plan to perform, and you start to think ahead about how you're going to get this patient safely through the operating room and out of the hospital and back home. Conversely, when you reach that juncture point, you may discover that there isn't enough information, that you need to do one of the following: obtain more blood tests, obtain more x-rays, maybe ask one of your colleagues for a consult. Maybe they can help you figure out what the diagnosis is, or sometimes you just use the tincture of time. It's interesting that William Osler once stated that 85% of conditions will get better on their own, and the doctor will just take credit for what the body healed by itself. But conversely, you'll discover that with the passage of time, it becomes very clear that the patient needs surgery, and then you will move down that path of guiding the patient successfully through surgery. The reason I wanted to share that with you is because that is what the heart of being a surgeon is. You are a problem solver, a puzzle solver, who you have to have good interactions and communication skills with patients, and you like to do things with your hands. You like to solve problems. If that work that I just described to you is of interest to you, then you should look very carefully at a career in surgery. All of the other things you see on television can be sensationalized. So all of the prestige and the financial rewards and the titles and those types of things, those can come and go. But if you're going to have a long and sustained career in surgery, what I just described to you has to be the intrinsic reward. And I can say pretty much with certainty that that will be what the practice of surgery at its heart will consist of throughout the decades. It's an amazing path. I would definitely do it if I had to choose over again. It opens so many doors of wonderful opportunities for the future. Careers in trauma surgery, just to clarify, after you finish, you're all college students, is that correct? So first, acceptance to medical school, and we can talk about those steps. 4 years of medical school, and then you have to choose a residency. And so the choices, I'm really making an appeal for those of you to consider, and I'll explain very shortly, the crisis and access to emergency care. You have a choice. So if you wish to be an emergency medicine provider and spend most of your time in the emergency room, I believe it's a 3 to 4 year residency in emergency medicine. You don't become a surgeon. You don't spend time in the operating room, but I applaud all the great work that's done by our nation's emergency medicine providers. They're invaluable, and they're making major and important contributions. I think what we're all hearing about regularly on a daily basis now is about in the diagnosis of Ebola. They're the frontline providers who are really defending the health of the public. So emergency medicine is one option. The next step requires training in general surgery. It's an additional 5-year clinical training. In some programs that are research intensive at academic medical centers, it could be up to 3 years of research in the lab, but for some programs it's just 5. So once you finish general surgery, you can do an additional training in trauma surgery and in acute care surgery and in critical care. And so the trauma surgeon is typically an additional 1-year fellowship, and there are these special acute care surgery fellowships that I'll describe shortly that give you slightly additional certification. From where you're sitting right now, it's about a decade. So it's a good time to have this conversation, right? To discuss things early and to determine if, hearing of the work that's being done nationally, if this is something of interest to you, to make the commitment towards this career path. So what are the challenges in emergency care? A series of 3 reports from the Institute of Medicine in 2006 detailed a national crisis in emergency care. A crisis of hospitals closing, emergency rooms closing from financial forces, from the inability to have surgeons to take call, challenges in the treatment of children, ambulances that have to travel long distances and are diverted because hospitals are crowded and unavailable to accept new patients, patients who have to spend long hours in the emergency room waiting for a surgeon to be available or for a bed to be available, so they instead are boarded and spend extended periods in the gurney in the hallway rather than in an actual hospital bed. There was a story from an elected official I heard a few years ago, kind of details how bad this crisis had become. They got a call from a friend who asked them for help in finding an oncologist. And I think you're probably all familiar that an oncologist is someone who specializes in the care of cancer patients. So the elected official told their friend, I'd be certainly to help your family member. I'm really sorry to hear that there's been a cancer diagnosis. And the person responded, cancer diagnosis? No, my mom's in the emergency room and they've been trying for about 36 hours to find the on-call doctor to see her. And he didn't know what the right term was, so he thought it was an oncologist. So on top of this national crisis in emergency care, there is a simultaneous crisis in access to surgical care. And this is really the heart of today's talk. Because of caps on training programs, earlier retirement, a trend towards practice in ambulatory surgery centers, concerns about litigation, and really wanting to have control over one's lifestyle, which is entirely understandable, there has been a difficulty for emergency rooms to find plastic surgeons, general surgeons, trauma surgeons, neurosurgeons, OBGYNs to provide on-call ER coverage. The American College of Surgeons summarized this very well in early 2000s in this report. Declining reimbursement was one of the main concerns that they cited as well. To try to address and to try to reinvigorate trauma surgery, I give them credit first. They conceived of a new model for the delivery of care in the United States. The stories, as Atul has written about the success stories of trauma, they continue. But in the early 2000s, it was believed in America that something needed to be done differently to attract bright young minds like yourself to consider a career in trauma. So they looked to Europe, they looked to Switzerland, they looked to a model where trauma surgeons perform limited orthopedic procedures, neurosurgical procedures, angiographic procedures. If there's a hematoma bleeding into the brain, they will place a burr hole. Their fractures, they'll try to repair them. It was an attempt to increase the scope and number of procedures that trauma surgeons would perform in the United States. You can anticipate, it's a very interesting political lesson of what happened next. As you might imagine, the neurosurgeons and the orthopedic surgeons, the leadership of their professional organizations went to Capitol Hill and said that this is not safe for patients, that it would be best if people who are more experienced in those organ systems and performing those procedures were to continue to do so. So a memorandum was issued, and the field of acute care surgery sort of moved sideways just for a short period. It was around that time that I was finishing my residency in the early 2000s, and I realized that something needed to be done to reinvigorate general surgery, to make it more attractive to future trainees, and more importantly, to deal with these crises that we've heard about. We were facing local challenges at my medical center of particularly surgeons becoming very specialized, doing advanced fellowships, perhaps in endocrine surgery and breast surgery and minimally invasive surgery, becoming really, really good at doing a small set of procedures, but becoming quite uncomfortable in dealing with the broad variety of procedures that might present in an emergency room. The challenge is, I'll be honest with you, being a surgeon is hard. Dedicating your career in emergency surgery is sort of doing the hard part of an already hard job. You have to work and deliver care in the middle of the night, on weekends and on holidays. I applaud all of the emergency providers, nurses, emergency medicine, and across specialties who put themselves on the front lines and who deal with many patients who are of a poorer payer mix, who may be uninsured. The risks of your patients dying are higher, the risks of litigation are higher, but it is also a vital need for our nation, for our national security, for our public health, to have people available to take calls. So at UCSF, what we conceived of was the surgical hospitalist. We introduced a model in 2005, and we tried to turn everything around. Rather than having surgeons focus on their elective practice, being in clinic in the operating room and coming to the emergency room afterwards, we turned it upside down. And we proposed that you have a dedicated emergency surgeon who wouldn't be committed to any of those elective procedures and would respond to consult requests from the ICU, the wards, and the ER as necessary. The acute care surgeons, to their credit, adopted that principle of the dedicated trauma surgeon as well. And it's very interesting to me to see that these two fields, which started from very different places over the last decade, are merging and they're unifying to meet the needs of the nation. Slides like this highlight the national challenge. This is from 2009, surgeons per 1,000 population. The areas in dark green are areas where there are plenty of surgeons available. You'd probably notice that those are in the more urban, metropolitan, and desirable areas to live. All of the white squares that you see on this map are places where there is no surgeon available to take call. There are over 1,000 counties in the United States of America where there is no surgeon available. And it was really for that reason that we proposed these new models of the surgical hospitalist. I'm pleased to report to you that there is great reason to be hopeful. Over the last decade, there are an estimated 500 acute care surgery and surgical hospitalist programs that have been adopted in the United States as a solution to the emergency surgical crisis. I hope by the time that you enter the workforce that this evolution, this progress will continue forward, and I hope that this will be a very vibrant and sustainable career path. There are a lot of really interesting developments that have positively impacted the perception of the White House, Capitol Hill, HHS in this regard, that really speak to the importance of sustaining our emergency care system and also the heroism of all types of emergency providers. So I'll share those with you. The first was in 2011. It was the mass casualty event in Tucson, Arizona, where Congresswoman Gabrielle Giffords and a number of bystanders were injured. It was worried initially that she would not survive, and then later that she would not have a reasonable recovery and be able to return to work. Fortunately, it was all of the teams of doctors and providers, especially the gentleman in the right of the photo, Dr. Peter Ree, who were recognized for her amazing recovery. And it really catalyzed a change in perception on Capitol Hill, particularly because Congresswoman Giffords is one of the colleagues, of everyone in Congress. And they really started to take notice and to speak about the importance of our emergency care system. The second event came in 2013. It was the Boston Marathon bombings. A tragedy, but there was a silver lining. There were nearly 200 patients transported from Copley Square to Boston hospitals. The only fatalities were pronounced at the scene. It's really a tribute to the spectators, to the people who had advanced medical knowledge, who applied direct pressure to the arterial injuries and who put tourniquets. It's a testament to the paramedics, to the emergency medical system, to the nurses, and to everyone involved, that all of the patients who were transported to Boston hospitals survived. It was particularly pleasing for me, having worked in this field of emergency surgery, to see that it was the programs at the Massachusetts General, the Brigham and Women's Hospital, and the Beth Israel Hospital, the surgical programs that were involved in this outstanding recovery were all the acute care surgery programs. And I think it was really, for me, crystallized when President Obama went to Massachusetts General Hospital to meet with the survivors and again to speak about the importance of sustaining our emergency care system. Dr. Gawande wrote an article in the New Yorker trying to understand why the outcome in Boston was so favorable. This is some of the excerpts that I really think highlighted the national attention, the research, the grant funding, the efforts to look at mass tragedies internationally that are really improving disaster preparedness and planning in the United States. Lessons learned from Aurora, Colorado, and in Newtown that I think will lay the foundation for strengthening the system in the future. There's some pretty interesting ideas in Capitol Hill. One has been to create a national health service corps in emergency care, realizing the lack of personnel to care for patients in all of those white squares across the country. It has been proposed, and it is being considered in HHS, to develop a national health service system whereby surgeons and providers across all specialties are certified, are deployed, provide care, return, receive feedback and ongoing education, and then get deployed once again. I think by the time that you reach the workforce that this is an idea that you're going to hear much more about. I think that the next level of solutions, and for those of you really particularly interested in public policy and careers in government, I spent a year in Washington, D.C., and what I noticed is that many of the physicians who are leading the important discussions about health reform have backgrounds in emergency medicine, in emergency surgery, or in military medicine. Examples such as this is Senate Bill 1873 that was proposed by then Senator Barack Obama before he became president. And he recognized the importance of sustaining and continuing research in emergency care coordination and regionalization. And he asked Congress to allocate, at that time, $12 million in around 2007 to support our emergency medicine research and medical response. This bill was not signed into law, but the crafters of the Affordable Care Act recognized the need to strengthen the emergency care system. They recognized the dangers that emergency rooms might continue to be overwhelmed. And so they took this bill almost word for word and inserted it into the Affordable Care Act. And so I think there is the special opportunity to harness opportunities in Washington, D.C. to strengthen our emergency care system. One of my mentors at UCSF, he was the chancellor. His name is Haile DeBass. He's one of the preeminent general surgeons in the United States of America. He would end every correspondence, conversation, and email with a two-word message that I want to plant inside of your minds now. He would end by saying, "Think big." So for the very final thoughts, I really appreciate it's wonderful to see so many of you here interested in careers in emergency surgery and across specialties. There's so many amazing things that you can do. I'm often asked in the health reform debate, what is the future of healthcare? And that's a very difficult question to answer. It's very difficult to know which particular parts of the Affordable Care Act will prove successful, which ones will fail, which ones will be deleted, and which ones will need to be revamped. But the one thing that I do know, what will the future of healthcare be? It will be defined and shaped by those of you in this room who choose careers in medicine, possibly in emergency surgery. What you do in your professional careers, in your research, even in your personal lives and your hobbies, you will be working on the front lines of that future healthcare system. And I'm really impressed that so many of you are here on a Sunday afternoon to invest the time to look at the future career opportunities. It's interesting to reflect that 10% of the signers of the Declaration of Independence were physicians. It's my personal hope that we will have 10% of our Congress as physicians as well. There are 535 members of Congress. It was encouraging. I think actually in the 113th Congress there are about 20 physicians as well. I hope we can reach the number of 54, which would represent 10% of Congress. But I wanted to leave you with the thought of thinking even bigger about what you can do during your lifetimes to really transform the healthcare debate. I think the most important defining event in the health reform discussions over the next decades will be for the first time in our history, for a physician to be elected the President of the United States of America. Throughout our nation's history, lawyers, business people, war heroes have traditionally been our presidents, never a physician. I believe it. I think that any one of you in this room, you can do it. If you dedicate yourselves, the vision and the support of your colleagues, I think it is a goal that the profession should collectively aspire to. I would perhaps in comment say that along this journey of health reform and being in emergency surgery, you meet a lot of interesting people along the way, like Captain Sullenberger and the people here. I would just say it's an amazing and wonderful career path. I would, if I had to, definitely do a career in surgery once again. If you are interested in government, and some final thoughts about success for application to school. In Washington, the fellowships I would strongly consider that you consider applying for are the White House Fellowship, the Brookings Institution, the Robert Wood Johnson Fellowships. These are the opportunities for clinicians, healthcare individuals to have a say in the discussion. You may recognize the names Sanjay Gupta and Colin Powell. They were both White House Fellows, and that's how they got their career started. For you right now, take a close look at the Rhodes Scholarship and the Marshall Scholarship. These are two prizes that I didn't even learn of until after I had graduated, but these are the two most prestigious awards that a college student can receive in the United States. They are based on academic accomplishment as well as athletic performance. And I'll give you a little hint that if you were to secure one of those two prizes, you pretty much have guaranteed your acceptance to medical school in the United States. You'll find the medical schools clamoring for you to enroll in their schools. I'll finish by saying thank you so much. It's really great to be part of this amazing program. I'd be happy to answer any questions, and feel free to write to me through Twitter or my Yahoo account, which is my last name, underline my first name. So best wishes to you, and I'd be happy to answer any questions.